The Epilepsy Foundation acknowledges the Wurundjeri people of the Kulin Nation as the traditional owners of the land on which this property stands. We respectfully recognise elders both past and present.
I'm Gabriel Dabcheck. I'm a paediatric neurologist, subspecialised in epilepsy. Today I'm talking about epilepsy in adolescence. So the main task anyone faces in adolescence is transitioning from being a child to being an adult. And that requires a lot of different steps. So as a child, you're reliant on your parents for pretty much everything. And including that is your sense of identity. So your identity as a child really, and that speaks to the way you see yourself in the family, in the community, your interests, your likes and your dislikes, your religion, how you conceive of yourself as what kind of job you're going to be as an adult. It really relies on your parent. And as you go through adolescence, it's all about acquiring those skills to become an independent adult. So you have to form a sense of identity in friendship circles, in wider social circles. You need to form a sense of identity and independence in relationships. You need to form a sense of independent identity in terms of what kind of vocation or what kind of job you want and what your educational tasks are, as well as your sense of fun and your sense of enjoyment. So it's the main thing that everyone faces. Now, adolescence for everyone is difficult because acquiring a sense of independence requires a lot of trial and error. And with that comes a lot of error. And you need a fair amount of resilience to get yourself back up and keep experimenting with things and keep investigating new things to acquire your full adult identity. And when you have a medical condition, it adds on an additional complication because often you're advised that you can't do certain things and that you have to go to medical appointments and that you have to take your medication and you're advised not to stay up late. So that really makes the normal tasks of adolescence a lot more complicated. Now, with patients with people with epilepsy and children with epilepsy, as they become adolescents, they develop more independence. So one of the normal tasks of adolescence is taking over the care of your own medical needs. And so that becomes an issue during adolescence, that instead of your parents telling you to take medication, the onus will eventually be on the adolescent or young adult to start taking the medication. We all know that one of the things that triggers seizures is sleep deprivation. And so as you go through adolescence and young adulthood, people tend to go out late, to celebrate things, to stay up late, and that puts them at additional risk. So that is another complication that people with epilepsy face. And then once you get to your later teenage years, there's the whole prospect of driving, and that adds additional complications, which can either be reasonably easily overcome if the client's epilepsy is easy to manage, or more difficult to overcome if the person's epilepsy remains refractory. I'll speak to the medical risks first, and then I'll go on to the other ones. So one of the tasks that we encourage adolescents to do is to start taking control of their own medication, which means take your medication at your own schedule, 8 o'clock in the morning, 8 o'clock at night. And because as you're passing through adolescence, you're gaining independence, it's not necessarily going to always work. So people sometimes forget their medication. Adults forget their medication. And that does confer an increased risk because we know that some patients are quite sensitive to forgetting their medication. So that's typically a conversation between the patient, the doctor, and the client or the patient's parents, because that's often a task that we delay until later in adolescence just because we know of the risk that's involved. It's a very important task because as you're passing through adolescence and young adulthood, you won't always be around your parents. You'll travel independently, you'll spend nights at friends' houses, you'll go away on camps, and it really speaks to the fact that you need to have the independence and responsibility to take your medication at the appropriate time. I spoke briefly about what happens when you're sleep deprived or staying up late, and that also ties in with the whole idea of partying, that we live in a culture where it's expected that as you pass through your teenage years and into your early 20s, that you'll go out and you'll experiment with alcohol and other substances. And we're fully aware that our patients with epilepsy are just like everyone else out there, and that they get up to no good. And it really speaks to the client with epilepsy should discuss this with their parents and their doctor, because it's the combination of alcohol and sleep deprivation and forgetting your medication, because often those circumstances go closely together, because you go out, you have a big night, you forget to take your medication, you don't get to bed until 2 o'clock in the morning. With the alcohol on board, you wake up at 6 o'clock in the morning, you don't take your morning medication. And they're the circumstances we see where a lot of teenagers and people in their 20s have seizures. So it's really important to be aware that there's that risk involved, and that you're putting yourself, or the adolescents putting themselves at a lot of risk if they consume a lot of alcohol, take other substances, and then are sleep deprived. Now, it's our responsibility as clinicians to meet people where they are, and we're aware that people go out. So there are some things that mitigate this risk. So taking your medication at the appropriate time, trying not to have more than 2 or 3 standard drinks, and trying to get adequate sleep. So they're the most important things. And also taking your medication when you wake up the next morning, and doing all this in the company of responsible friends, because that's very important. Just because if your friends know what your medical complications are, and this speaks to if you have any different medical complications, should there be a crisis, they will know what to do. That's the medical. And I guess that really ties in with the social, because the social has to do with the increased risks of having seizures during your adolescence, and that's generally sleep deprivation, drugs and alcohol, and partying. So they all tie in together. An additional task that's made more complicated, which we touched on, is driving. The way the government and the regulatory bodies have created the driving regulations, the onus of the hurdle is not too high if you have well-controlled epilepsy to get a driver's license. If you do have well-controlled epilepsy and you get a driver's license, you need to your clinician needs to fill in the medical report every 12 months while you remain on medication, and then for 5 years after. So after a while, it does get frustrating, because you're on medication, you've got well-controlled epilepsy, but every year you need to file the same report. So in terms of patients transitioning, there are really 2 groups. It's best conceived of, there are 2 groups in the way they transition from paediatric care to adult care. There are patients who have epilepsy that's not very complicated, that's easily controlled with 1 or 2 medication. And the usual process is that your paediatric neurologist or epileptologist will find a neurologist or epileptologist in your area, and then they'll write a transfer letter. And then that will happen sometime at the end of the year 12 or the year 12 equivalent, be it VCAL or another course. And then the transition will happen at the end of school. We like to keep it to the end of school just because we know that the last year of school involves a lot of flux and a lot of different things are happening in the young person's life. And then it's like a hard stop. You see your paediatric neurologist, they say there's a build-up over a year where we're going to send you what transition involves, and then a letter is written that you should get a copy of, and the adult neurologist should get a copy of, and then the client or the patient will go and see the adult neurologist, who essentially starts again. They should have all the information, and they'll take your history, they'll go through everything, and then continue with your medical care. If you have complicated epilepsy, you're managed through one of the tertiary hospitals, there's often a well-developed transition program that you'll pass through. So the transition programs often start engaging with you at about 15 years of age, and they work on your skills to transition through adolescence. So those things we went through before, including the ability to gain independence in your medical management and a sense of agency so you can make decisions for yourself. And then as you get to towards the end of year 12, the beginning of the year after, there might be a joint clinic with an adult neurologist and a paediatric neurologist where there's a formal handover. And then after that, you'll then go into the care of the adult neurologist at their hospital or into their private rooms, depending on the circumstances. I think that's really important, that as you're getting to the end of your time with a paediatric neurologist or a paediatrician, it's really good to have all the information on hand, because to have a digital copy or a paper copy of the EEG reports, if you can get a digital copy of the EEG, that's very useful. A disc or a USB of the MRI studies, because medical information is very fragmented and it's often very difficult to get it for the adult neurologist to get it if it's 5 or 6 or 10 years old, because that will often be the most up-to-date imaging, and it will save us a duplication of investigations, a duplication of resources as well. So the transition programs do make a very good effort into creating a pack for you, which has all your medical information and printouts and digital information, medical imaging. Not everyone passes through a transition program because they might be seen in a hospital that doesn't have a transition program or at a private clinic. And then it's really the onus is on both the doctor and the patient and the patient's family into asking for a copy of everything, because that's very useful when you're an adult neurologist, because I've been in the circumstances of being the person transitioning, and I've been in the circumstances of being the person accepting the transition. And it's very useful as the person accepting the transition to have all the information there, because then you're not relying on hearsay, because you can go back and see the raw data yourself. Oh, your doctor should provide it, but life is busy and there are often many push and pull factors when you're in clinic, and you're often dealing with active medical issues, so it's not a priority. So it really helps to ask, because all that information in clinic is now very easily available through the medical record, and it should just take a couple of minutes for the clinician or the staff to pull it all together. The Royal Children's Hospital does have a transition program, and there is a transition clinic. It's mainly patients with refractory epilepsy who we know are going to require ongoing involved care from one of the big tertiary centres, be it St Vincent's, Royal Melbourne or the Alfred, and that's run by Simon Harvey. It happens 3 or 4 times a year. It's very well organised, and it brings together the epileptologists from the major adult centres, and the patients are seen both with the clinicians from the children's and with the clinicians from the adult neurology hospitals. I have my own children, they're young, and I remember being a child and adolescent, and you don't necessarily believe anything the adult at the other end of the table is going to tell you, and especially a removed figure of authority like a doctor. And so kids and teenagers think they know better, and they don't listen to their parents, and they go out, and and I often have this conversation, is that it's going to be like your life is going to be risky with this continued behaviour until you're in your early 20s, because most people don't fulfil the tasks of adolescence until they're 25, 26. And a lot of it depends on who your friends are, because kids do what their friends do. So I start telling patients when they're 14, 15, like year 8, like, do your friends go out and drink? Do your friends go out and get up to no good? And you should really, and I make it clear that you should hang out with kids who don't go out, especially in that year 9, year 10. By the end of year 12, not everyone, but nearly everyone's getting up to no good. But the kids that start early, it just increases your risk period. And so you kind of make that clear, and you kind of tell the parents that, knowing that the kids aren't listening to me, they'll choose to be friends with whoever. But the parents should have the ability to have an impact on the friendship circles, at least at a younger age, so that can defer the lifestyle choices. And then a lot of it's about safety, because once kids are in social circles that go out and go partying, it's about harm minimisation. It's about going out with people that are aware of your risks and trying to limit the consumption of alcohol. I've got a friend who's just completing a PhD about adolescence and type 1 diabetes, and I had this conversation. It's the same, different medical condition, but it's essentially all the same issues. And one of the things that he says is the patients, if they're going to take drugs, just take one drug, don't mix your drugs, and make sure that there's someone there that's responsible. And you can have we have these conversations in clinic. I don't know how much the patients hear, and it really does often. You think that it requires something terrible to happen for them to wake up and realise how much risk they're really in, but it's and you try to explain this to them, that if something terrible could happen, and it might be the only time it happens because you might die. How much they listen, it's entirely unclear. But the aim is to meet them at their level, and there's the principle of harm minimisation. And I get the transition letters back from the adult neurologists, and they don't pull their punches in terms of they spell out what they discussed in clinic and the risk of death and the risks of going out and the risk of sleep deprivation. So we know that patients hear it, but I do not know, and I couldn't find any literature about epilepsy in adolescence, and are there any impact factors that can change people's lifestyles? But I would be very, very surprised if anything actually changes people's lifestyles, because kids will be kids, and patients with epilepsy, just like everyone else, they just want to get on with their lives. Thank you for your time, and thank you for watching my webinar. If you have any further questions on this topic or any topic relating to your epilepsy or the epilepsy of a member of your family, please contact the Epilepsy Foundation.